Good to see lots of people on today. And I am pleased to introduce Dr. Sharon Mo. Dr. Mo is Associate Dean for Clinical and Translational Research, co-director of the Indiana Clinical and Translational Sciences Institute, and the Stuart A. Kleit Professor of Medicine at the Indiana University School of Medicine. She's going to talk to us today about the Indiana CCCR, an untapped resource for musculoskeletal researchers. So I'm looking forward to hearing about that. And Dr. Mo, whenever you are ready, please take it away.
All right. Well, thank you so much for the kind introduction and the opportunity. Hopefully, let's see. Can you see my slides?
Right now I'm seeing I think your Google screen.
Let's try this again. I was trying to be all set for it and then I think it was another one.
There we go.
Okay, great. Just gonna hide all these things.
We see your presentation okay, Sharon?
Okay, great. I'm just trying to hide all the meeting controls so I can see it. All right, well, it's a pleasure to be here, and I want to point out all of our colleagues that are listed here are on the call. Mike Econs, who is the co-investigator on the overall, or co-investigator on the overall grant, the associate director. Stuart Warden, who is the PI on the resource core, and Eric Emmel, who is the PI on the what we call big data omics, or the methodologic core, and Cody Alther, who is our navigator. So I'm sure many of you find the CCCR being a mouthful. So we basically abandoned that term and call ourselves the Indiana Center for Musculoskeletal Health Clinical Research Core, or Clinical Research Center. So the ICMH itself has about 130 members from multiple institutions across the state of Indiana, and is largely more basic science and translational science. And so we like to think that we kind of help them see the clinical view of that research. So that's why we're sometimes called a core. Sorry about that. Okay, back to this. Can you see it again?
Yep, looks
That's good.
Great. Okay, so our mission is really to provide training and resources to enhance clinical research in musculoskeletal disorders through the use of state-of-the-art technologies to define, characterize, and measure genotypes and computable, molecular, functional, and morphologic phenotypes. Quite the mouthful. This is the way that we are set up as our org chart. And basically, Mike and I are the directors. We have an internal steering committee and an external advisory board. We work closely with as I mentioned, the Indiana Center for Musculoskeletal Health, which is divided into some thematic research teams, which have both a clinical representative and multiple basic representatives. Our administrative core is really led by Cody, who's on the call here today, and he is clearly our anchor. So any questions through him, he'll triage, get it to the right person. We have our big data and omics core, which is largely based, as I'll explain in a minute, it's largely based around health informatics, and then the resource fit core. All right, so our resource core we call the FIT core, standing for function, imaging, and tissue. And this is really the collection of human data. We also provide consultation on human clinical trials to collect samples. The big data and omics uses electronic medical record to look at patient information. We'll go through that. And of course, the administrative core basically tries to keep everything together. So the FIT core, again, is function, imaging, and tissue. It's a great name, cute name. Stuart gets all credit for that. And it really is to provide access to and training and outcome measures of physical function and imaging, and collect specimens. So we are we just finishing up on our year 6 of our grant. And so the way this works is that participants, whether they're in other studies and we use these as an endpoint, or whether they come off the streets through advertisements and social media, they come to the FIT Core. So they participate, and I'll explain what that is in a second. And so far, we've had over 3,800 participants come. 4,300 have donated specimens. We collect them in the OR. We have lots of vials of serum. We have engaged 48 investigators from multiple disciplines. And this is the data we used a year ago for our renewal. We had 63 million in funding were submitted using our FIT Core. So what exactly is the FIT Core? Well, our goal is really to provide normative reference data from a healthy generalizable population. The inclusion criteria for coming and participating in the FIT Core is actually age 5 to 90, nothing else. So we actually use a lot of novel methodologies and approaches, and we want to actually use this as, let's think of it as both a reference normative database, but also a way to have other people conducting research use musculoskeletal endpoints as part of their clinical research. So what happens here? So the participants come into this physical space in our clinical research center, and they undergo physical function test battery, patient-reported outcomes. They get blood collected, and then their information is actually linked to the electronic health record. They undergo dual X-ray absorptiometry, which is bone density, but we also look at whole body lean mass and fat mass. And then we analyze the patients on high resolution peripheral quantitative CT, which, as most of you know, is a great technique to really get at the architecture of the bone and compartmentalize cortical and trabecular bone. So the physical function tests were selected after getting together with everyone on campus who does these, so that we have standardized tests chosen by everyone. And this includes the gait speed, usual and fast, grip strength, repeat sit to stand, timed up and go, 6-minute walk, and static balance. So we not only do them in our core, but we will train other people's coordinators to do the same tests so that they are doing them in a standardized fashion. And then they can use our data set as their controls for their study. We do patient-reported outcomes, including the SF-36, the PROMIS. We added this year the Health Leads Social Needs Screening Tool. And then we also added a question on the use of supplements and dietary patterns, carnivore, fasting, et cetera, from validated NIH surveys. So we just took some of those questions because the survey is too laborious. So participants come in, they sign a consent, we run the large consent, and even if people are in another study and use us as an endpoint, they just have to reference our IRB in their conformed consent, and then we track all the participants, keep track of all the consents, et cetera. All this information is listed in an Encore database. Some of it's in REDCap. So again, our progress, 4,800 total visits over 6 years, including the pandemic, which we're very proud of. We are really trying to get people to come back for repeat visits so that we have longitudinal follow-up. We have in our consent, we're able to call people for specific studies or things like that if we need them to come back sooner. 47 investigators have used our core. 28 prospective trials are using it. And as we mentioned, 45,000 blood samples. And then we also collect distinct tissues. So this is a separate part. It's under the FIT Core, but we did a whole teaching on how to do muscle biopsies right before the pandemic. But we have an arrangement with our orthopedic surgeons that if somebody needs tissues, that they can come and we'll try to collect them for us. Right now, we have a lot of that banked, as I'll get into later. So we've not been actively collecting more tissues because we need people to use what we have. All right, so our goal really is to provide normative reference data from healthy generalizable populations. So I will confess we went around what exactly is healthy. And initially we started with a self-perceived healthy. And so you have people who are on no medicines who don't think they're healthy and people who are on multiple medicines that think they're healthy. So we've done the best we can to kind of really look at a more healthy population, but we've termed that more healthy generalizable. So because there really is no such thing as it's self-perception of whether you're healthy or not. So then we use these novel methodologies and approaches and tools. And importantly, we've really reached out to all of our non-musculoskeletal researchers. So kidney disease, heart disease, liver NASH, other folks who we have convinced, cancer growths, to add these measures onto their clinical trials. So that, and the selling point is we do all the consenting, all of that piece. Then what happens is they don't have to recruit control populations for their group. So we have enough of an N that we can basically match for their patient population. And that makes it very popular. By us keeping track of that consent, it keeps us a little more compliant and on top of it with 4,000 people. All right, so the reference data, this is something that Dr. Warden has done a just fabulous job on, and really taking all of the data that we have and trying to get reference data. So essentially, we have reference data for grip strength and sit to stand test. So females to males, unfortunately, most of our recruit right now is mostly females, and have created a downloadable Excel-based reference data calculator. So many of us are familiar with a scorecard or a DEXA reference data where the patient gets the scorecard and they see where they are versus the rest of them. This is exactly what he has done in creating this standardized calculator. So you could take your data, plug it in to the spreadsheet, get all of this data, and you will get both a Z-score and a T-score. And the patient can get a handout, and we give them to this after they complete, as to where they are along the spectrum. The beauty of this is the patients get something, so there's return of results to the patient, which makes it popular with them. We get a little competition of families coming in and husband and wife's arguing over who's better. And then we also have the ability we screen these for the DEXA in particular, and we put them in their electronic medical record. It clearly states research only, but it again allows our primary doctors and others to actually utilize the data. We also performed HRP QCT reference data. So we have 4 sites, distal radius, diaphyses in the tibia, and diaphyses at these basically links. Same kind of population, and the same thing with the downloadable Excel-based reference calculator. Looking at the distribution, you can see across age, and then the patients get to this Z-score and T-score. So the nice thing about this is, again, from your research purposes, you can use these calculators to put your data in and actually get a Z-score and T-score compared to our reference generalizable database. So yes, it's Excel. It takes a lot of effort to actually get your data in correctly, but it's actually the best way to do it because it's so complicated. And as you know, for HR QCT, I mean, there is so many variables that pop out that it's kind of hard to do that. So we've limited to the scorecard helps you just get that into normative data. So we want people to use that. We're happy to have these. They will be available on our website. We're in the middle of redoing that, but you can go to the journal supplements, or you can email us and we will send those to you. So how do you use the reference data? So here's an example, a study Dr. Immel is doing, looking at bone health and cystic fibrosis. So 50 patients, here's the age, and there's a lot of things in the literature where people say, oh, it's off, you know, that they have bone loss, but they haven't necessarily looked at it compared to controls. So if you look at their physical performance, you know, their Z-scores are normal. And then if you look at bone, particularly with the HR, you see a distinction between some of the cortical parameters in terms of being worse or being lower in the cystic fibrosis. In addition, if you don't know much about HRP-QCT, there's the ability to do some really biomechanical-like measures on that, including stiffness and failure load, which may be more indicative or is probably more indicative of fractures. So again, the same concept that it is available for you to take your data and put it in. So new data, as Stuart has just got published, is really looking at this idea that, you know, I'm big boned and therefore I should have more DEXA. And even back many years ago, there was this concept of cross-sectional area increases proportionally with bone length that was discovered on regular routine kind of imaging or regular autopsies done in the past. So Stuart actually collected that data. And, you know, you look at these two and you think, surely they shouldn't have the same amount of bone, okay? So same type, radial and tibial diaphyses, same kind of group of participants. And then basically bottom line is that the bone length explained about 8 to 19% of variance in bone areas. So if you think about that, you know, we tend to look at people as if they're all the same size. And so knowing that this is actually a variance can help you with potentially explaining some of the variability in our research. So same concept again here, you have a scaled cortical area. So this is scaled based on the height and the ability to put that in a score sheet and actually get a Z-score for that. So just another way to take your HR data and make it just a little more basically specific for that patient so that it can helpfully limit the amount of variability. So currently work ongoing with muscle. One of the things that is collected with HR is actually a lot of information about muscle. And you can take that muscle data and actually calculate the muscle volume and importantly, the muscle density, which might be a better indicator of overall muscle health than the actual volume. And as you can see here that the muscle density actually goes down with age. But in addition, there are certain disease states like my kidney patients, I'm a nephrologist by training, that actually have much worse density, whether that's fat infiltration or else we don't know. So similar to that, Stuart is deriving some calculators that will hopefully give us some more normative data on the muscle. So other ongoing studies, just a hint of these, we have integrating HR QCT with deep and machine learning to achieve automatic segmentation and differentiation of cortical bone in CKD patients. So in some patients, particularly in CKD, that there's a lot of trabeculization of the cortex, and this allows trying to figure that out. We can do that manually now, but it is incredibly laborious. We have blood samples from all of our patients, and we have identified kind of cohorts that are high and low physical performers in their age group by deciles. And so we have been collecting metabolomic data from that. We are looking at the different effects of nutraceuticals on physical function and looking at the impact of different forms of exercise on HR. That's just a snapshot. Okay, so the Indiana Biobank is actually part of the Indiana CTSI, and it is a very voted one of the top 2 performing biobanks by Biosample Hub in 2022. So the second bullet point really describes all of the larger Indiana Biobank, over 100 specimens each week, support 42 specific biobanks, and that's what we support. And they are able to collectively or prospectively collect samples for investigators. Obviously, there's a fee to that, but as needed. And there's an online catalog for searching sample availability. As long as you're from any academic center across the nation, you can do that. So our FitCore, the patients have the option for blood and then children for saliva for the DNA part. We also, as I mentioned earlier, collect specimens for musculoskeletal surgeries. So we have quite a collection of those now. Most of them are from trauma patients. So, you know, if you're looking at cytokines or anything else that might affect it, but that information is in this catalog. So we can connect you to that catalog and you could actually search for that and see if there's some samples that would be of benefit to you. You would have to pay to get them shipped to you, but other than that, they're free and academic and support of academic research. So we also, the Indiana Biobank has recently signed a collaboration with Regeneron, and they are doing whole exome sequencing. Over 47,000 samples of the biobank will be sequenced by August 2024. And by 2027, we had 6,000 samples for liver and matched controls. And then in 2020, they are now sequencing as we speak 2,800 samples from our FitCore. So basically, we'll have genomic data from all of these individuals that have been through the FitCore. Hopefully this will be expanded and we'll get everyone through it, but we're close to our full FitCore being genotype. So what do we do with all this information? Well, it links to our musculoskeletal big data and omics core, methodologic core under the the FOA. All right, so the big data and omics core really supports statistics for clinical research studies. Also, we'll do study design and data support, and probably the most of the bulk of the activities are electronic health record queries. So Indiana is home for the Indiana Network for Patient Care, which is a very large patient care network that actually links data from multiple health systems throughout the state for clinical use. So when we see a patient, for example, we can click on and find out what happened in other hospital systems. Then that has a contract with the Reagan Street Institute to use that data for, the INPC uses the data for research purposes. So we can do pilot and feasibility analyses. We will pay for queries to be done. Do you have X number of patients with this kind of problem? Then we can actually integrate the people in the FIT core to this electronic medical record. So when they come into the FIT core part of it, we make sure they have a medical record number that we link. There's a very quality process in matching different medical records from different health systems to get to the one person. So we assign them that if they don't have one, and that way anything that happens to those individuals long-term can be identified. It also allows us to match them to any healthy controls if they're looking at just data. So the way we're putting this together is what we're calling a data mart. So essentially, we have the IHIE, the health information data that comes from over 120 healthcare entities, some claims data as well. And then we have much more robust data from our two major health systems, IU Health and Eskenazi, our safety net hospital. All of this data has been converted or is being converted into OMOP, which is just an operability language between different systems. So basically the data comes in with SNOMED diagnoses and allows us to actually put this together. So we developed a musculoskeletal data mart. We have 1.3 million patients in that have some sort of a musculoskeletal diagnosis code. So this could range from an orthopedic surgery to hyperparathyroidism to hypophosphatemia to osteoporosis. In that musculoskeletal data mart, then we have information as to whether or not that particular individual participated in the FIT core and whether or not they have samples in the biobank. So it allows you to look at all of the patients that have all this data. We can query it for you to see the feasibility. And then we will be trying to link it up to our POLIS Center, which does geocoding for Savvy data in case you're interested in health disparities. We just saw our first full demo last week, and basically we in our core, Cody in particular, can do some initial feasibility to see what kind of data exists for that. So using this or using the larger INPC, we can actually look for other EMR data. So we have all of this information in here. We have some prescriptions. We don't know if the patient takes the drug, but we at least know if they were prescribed it. And we can do data with that. And we have the statistical expertise. So hospitalization, time to event. So like we can calculate the probability of sarcopenia and predicted death. We'll show you that in a little bit. So what are some examples of people that have done? So you can have, for example, recruitable postmenopausal women for grants. Okay, so this is great for grant feasibility data. We can do controls where we can generate and exclude specific diseases or medications. So we have a study where we're excluding people who were in the FIT core that have certain disease states or on certain medications. We can do FIT core subjects with and without certain medications, example, and then we can look through the whole INPC database or our musculoskeletal data for patients with, for example, stress fractures and breast cancers. So as those of you that do large data research, this is clinical data. So it's not perfect. It's not a clinical trial data set. So it's all up to what kind of SNOMED and ICD codes that the clinician and the coders put in. But that's the beauty of it, is that it's also real world data for generalizable research. So how do we look at this? Well, we look at our clinical or basic research scientists that can use the FIT core to identify specimens or data. And then they could potentially use the data mart to obtain more clinical information. So we have basic scientists who are doing work on muscle, and we have them getting our muscle tissues, and they might want muscle from a patient with or without a specific medication. So we can link all that together to get them those muscle samples that they can then run their RNA or whatever else on. On the other hand, we have our health services research person who then could use the data mart to identify a cohort to test the hypothesis, measure outcomes. And as you read those papers, you know that it's typically hypothesis generating. And so if there is enough people in that cohort they identify that have been through the fit core, they might be able to get to a more mechanistic design with the various tests and measures that we do that are standardized. So we are looking for individuals who want from either of these spectrums that actually want to learn more about the musculoskeletal services. So summarizing and here and showing you a couple more examples is that our mission is really to provide training and resources. And what we really want are more of you to use our cores and for you all to spread the word. It's really important that we utilize all the data that we have collected, all the normative data we've collected, the Z-scores that have been done. And as you can imagine, we're all used to this. It's hard to get that word out. So let us give you a couple examples of the power of this. So first, I'm going to hand it over to my colleague, Dr. Warden. Stuart, you want to introduce yourself as well?
Sure. So I'm Stuart Warden. I am the PI on the resource core on the P30. Trained as a physical therapist and associate dean for research within our school. And so I've been running the fit core and taking a lot of that data and seeing how we can make these reference databases to try and help investigators on our campus. And so we have, like Dr. Mo said, we have a lot of trials coming through the fit core right now. When we first started 6 years ago, we were testing a lot of people off the street, anyone who wanted to be tested. And that's how we created these reference sort of normal databases. And since COVID, we have transitioned a little bit more towards investigator-initiated trials, but also testing whoever wants to come through and be tested. And so one study that we've been helping with is looking at collegiate level cross-country runners and bone stress injuries or stress fracture risk. And so we looked at two cohorts of collegiate level runners. So these are all girls who have made it to the collegiate level. So they're all high quality runners. We split them into two groups. One group who only ran when they were younger and didn't play any other sports. So they've just basically specialized in long distance running. And then there was a group of girls who sort of molded into becoming a runner later in life. They played other sports when they were younger, including soccer, basketball, gymnastics. And so we had these two cohorts of runners who are all at the same level in terms of running. They just got there in different ways. And we were interested to see what was the benefit of this multi-directional sport on their bone health. Advanced. Yeah. So we used our HR-PQCT and developed some novel methods of scanning different sites. So the traditional sites on the scanner include your distal radius and your distal tibia. So in this study, we're interested in some sites that were also at risk of stress fractures. So we were looking at the navicular in the foot. We're looking at the second metatarsal, both in its midshaft or diaphysis, and also at its proximal end. We looked at the proximal end of the fifth metatarsal as well as a common site for bone stress injuries. And then obviously at the tibia, and whenever we take a tibia scan, we also get the fibula. So we looked at the fibula as well. And then so when we analyzed these two groups, we found significant differences in their bone health. So if we advance, so at the distal tibia, the girls who played multi-directional sports when they were younger had nearly 20% stronger distal tibias. And so there was a lot of factors contributing to that, including more trabeculae, thicker trabeculae, thicker cortical thickness, increased cortical thickness. And then the next site, we looked at the fibula. They had bigger bones. They had larger cross-sectional areas, similar in the metatarsal. We didn't find anything in the tibial shaft, which was interesting. But definitely trying to translate some of this sort of these technologies and develop new techniques to try and answer clinically relevant questions about, in this case, bone stress injuries, stress fractures, and sport specialization when younger.
All right, and then we will have time to answer questions about that. And then next is Dr. Eric Emmel. You want to introduce yourself, Eric?
Hi, I'm Eric Immel. I lead the informatics core and dealing with big data and doing studies looking at musculoskeletal outcomes in the setting of large electronic health records based databases. As Sharon mentioned, we take advantage of this Indiana Network for Patient Care, which is one of the largest multi-health systems health data exchanges. So we get information, again, not just from our own hospital or our own hospital system, but some data beyond that from other systems as well throughout the state. This was a project where we were really trying to tackle, the fact that sarcopenia is not really well diagnosed. It's a lot of doctors know about it, but it doesn't often end up, being addressed or diagnosed until very late. And so one of the things that we did was we tried to look at, well, what are some other things that indicate that likely indicate sarcopenia? And so sarcopenia is low muscle mass and low muscle function, but there are some related concepts that often overlap in those conditions, and that includes cachexia, where someone has general nutritional loss and inflammation contributing to muscle loss as well. And frailty, which admittedly goes beyond the muscle, but also to neurologic and joint function, and some other aspects of somebody's overall healthcare. But patients in all of these categories generally have low muscle mass. And so we did a study just trying to look simply at text notes and text terms and at ICD codes. You can see here on the left that the message that really came out of this is that very few people who probably have sarcopenia have any mention of sarcopenia either through codes or in their text notes. We found a little over 9,000 people who either had codes or text terms. The vast majority of those people were only detectable by text codes within notes. And when we tried to look at the notes themselves, and this is very labor intensive, to try to figure out, are they saying this person has this condition or that they don't have this condition? And almost all of them were saying that they do have this condition, or at least what we could tell from the notes appeared to be the statement. A very small percentage of people had any of the relevant ICD codes during this study. And this was admittedly not long after this, only a year or so of this time point for the study was after the introduction of the sarcopenia ICD code. But less than 0.1% of the patients that were detected actually had a sarcopenia ICD code, and very few of them actually had a sarcopenia text term. And the truth is, we sort of suspect that this still is a huge underestimate of the total burden of people in the state as a whole that would have evidence of sarcopenia if we were doing formal testing. And just for a comparison, one of the advantages is that in our FIT core, we are directly connected to the EHR data from our FIT core participants. So we were able to take the measures that Stuart and his group was doing and use the European guidelines, are the ones we chose to use, for thresholds for various sarcopenia parameters. And so we could divide our patients up into those who met sarcopenia criteria or who did not. And 19% of the adults in the FIT core at the time met at least one sarcopenia criteria, but only one out of that total, which is 0.4% of those who had some sarcopenia criteria actually had an ICD code. And that particular patient's had a sarcopenia code, but didn't have codes for cachexia or frailty. None of them had those either. And so what we set out to do on the next slide is to try to look at, can we look deeper at the health records? And we try to take a very agnostic approach to use machine learning methods to detect sarcopenia from within data that was within the EHR. And so this was a funded R01, and this is an example of one of the approaches. So we use the fit core measures as so-called ground truth, or our gold standard. And when we looked at EHR-based diagnosis codes, labs, medications, we were able to apply multiple machine learning models, and you can see 6 different examples based on the different colors in these graphs here. And we were able to do okay at predicting the patients who had at least one criteria for sarcopenia with the area under the curve that was about 74%. But we were able to get up to 92% area under the curve with these models, applying the machine learning models to try to tell the difference between those who had no sarcopenia criteria and those who had 2 or more sarcopenia criteria. Interestingly, we've tried to add in text notes, but it was very limited additional gain. You can imagine that if you have these sort of large, relatively large areas under the curve, that increasing them it's hard to move them further up. And I think one of the issues with text notes is the same problem as to why they're not having the term sarcopenia or the codes for sarcopenia in their notes, is that it's not being detected. And most of the terms that when we looked through and tried to figure out from the text notes what predicts how they did on the sarcopenia tests, they were very non-specific things, and lots of people without sarcopenia would actually have those. So we're working on some additional models. My colleague, Dr. Luo, is putting in another grant right now to try to explore some other approaches at trying to do even better at finding sarcopenia among the broader population just based on the EHR itself. We've done some preliminary data that I did not include in here, but that actually suggests that using our model for sarcopenia, we can apply that same model to the larger electronic health record and estimate an person's probability of having sarcopenia, which does turn out to be predictive of hospitalizations over the ensuing months or of death over the ensuing months. And we actually deliberately left out the COVID years when we tried to do that study because we didn't want it to be muddied by that. But this is just sort of a broad example of incorporating multiple aspects of the kinds of studies that we can do using our informatics score.
Thank you. So basically our goal right now, our standard curves are predominantly, while they're broken into men and women, they are predominantly a white population. And so we are working very hard to try to do some community engagement events and setting up shops at some local large health or community fitness centers. We really would like people, we have such collection of information. We would really love to have investigators spread the word, all of you, and utilize this. And again, we mentioned Cody's on the line here. And this is the email for the core for any general questions, and we'd be happy to collaborate. Happy to take any questions.
Thank you, Sharon. I don't see any in the chat yet. Any questions? Feel free to put them in the chat or just chime in.
We know that you all represent kind of the core people at your institution for any kind of musculoskeletal health. And so we're more than happy to collaborate with you. So
I have a question about your samples from the orthopedic surgeons. We're developing a biobank of tissue from orthopedic surgery. It's all knee replacement tissue, so it's osteoarthritis mainly. With your biobank, are you familiar enough to know if they have joint tissues, or this is limited to, since it's more healthy donors that you're trying to collect, if it's not, maybe it's muscle and other things that you wouldn't normally, like things like cartilage you wouldn't normally take out.
Right. So that's the beauty of a trauma patient is you actually get some of those tissues. Of course, the negative of a trauma patient is that they're trauma. But we do have some we do have some like knee replacement and things like that as well. The most collaborative of our orthopedic surgeons happen to be the trauma surgeons. And so that's how come we're kind of slanted in that direction. So we set up, we have a form that they fill out that gives us a little bit of information about the state. Like, so there's some that do say, osteoarthritis, and there's some that will say like it's the left. And sometimes, we get this glump of tissue and the surgeon has to identify these pieces in that. So we do have that form. We'd be happy to share that with you as well. So at least we could maybe, collaborate across that. And the beauty is because then the patient can go back, or the investigator can go back, and since we know who these people were, we can link for them and find out what their underlying diagnosis was.
Yeah, I think that would be good for us to do. Like I said, maybe start out by just seeing what tissues you have available. So, so I definitely want to do that.
Great. So Cody can follow. I mean, we can follow up. And I think our form, we spent a lot of time tweaking that with surgeons because, the left, the right, which part. I mean, honestly, you get this hunk. The first specimen we got was this hunk of a knee,
Yeah, I know the feeling.
And we're supposed to be expected to separate it all out, and that's just not really our skill set. So
right. Okay, thanks. That sounds good.
Yeah,
You guys are doing a lot of great work.
that's good. Yeah, and spread the word. When we get all of this stuff, all of our bio samples are going to be whole exome sequencing. We can really do a lot with anyone who's looking for genetic disorders. I'm excited about that part. Hermine, you had your hand up?
Yeah, Sharon, thank you for this presentation. You're so close, and I was unaware of all the wonders you're having, and could support us. Whom would we approach best for working with you together on muscle diseases?
So I mean, Cody, who's wave your hand, Cody, you're on the line. So he's our navigator. So we just have a central point of contact. We're happy to help. You can email any of us. But I think, you could send your initial query to Cody and he will either send it to Eric, to me, or to Stuart or Mike. So Stuart's probably your best muscle person. Are you looking at an actual samples of muscles or more just information about your HR muscle work?
Both.
Both. Okay. Yeah, probably Stuart would be the best contact, but again, we're happy to. So what Cody does is he gets these queries and then he sends it to all of us. It's just a way to get one email and not have to think of a lot of them.
Thank you.
Yeah, we'd love to work with you. Yeah.
Any other questions? All right, see one in the chat. I'll read it. Do you have cohorts already assembled of rare bone diseases that you have phenotyped, like osteogenesis imperfecta in adults?
Yeah, Eric and Mike, do you want to? I don't know if Mike's still on.
I can answer. Although he's coming off. We have some patients with XLH that have X-linked hypophosphatemia that have been through the cohort or through the core. We have an ongoing study of osteopetrosis. It's predominantly dominant osteopetrosis that we've been working really hard on over the past several years. We don't have a lot of osteogenesis imperfecta patients that have gone through that. Most of the ones that have gone through in conjunction with a clinical trial of like a drug clinical trial. And so that's actually one of the other things that we highlight about the FIT core is it's really what we if we are using or doing any other studies that need bone outcomes, DEXA outcomes, HRPQ-CT outcomes for either as a primary or main secondary outcome, or just as a completely ancillary study to somebody else's clinical trial, we have the ability, that's our source for doing that. So we don't run those things through like the hospital radiology system. We run them through our research core.
Right, so if there's a drug trial that's using DEXA or something, then
Yeah.
they'll use our core, and then we'll add on all the other measures.
Yeah.
So, yeah.
You know, for example, like today I just rushed over here for this meeting after seeing one of our OI patients that's going through the core.
Yeah, just to add in, people with rare disease typically don't just join up as kind of normal volunteers. They're part of a study. You know, usually there are study protocols, but again, this is why we put them in the fit core so that everybody gets kind of the same thing, and we have a large database for some of these rare diseases. We have roughly 60 people with autosomal dominant osteopetrosis, for example, that have been through the fit core.
Very impressive HR on that, yeah. Yeah, and I think the other big cohorts we have include lots of chronic kidney disease and dialysis patient, which of course, since I'm a nephrologist, we work a lot with that. We have liver patients, NASH, we have some cystic fibrosis, we have we're working on some migraine patients. Let me see, what else? Feel free to jump in, Cody, or anybody else. The healthies that Stuart have, we have cancer patients, a lot of breast cancer studies. Trying to remember.
Yeah, I think that hit most of the disease space. I mean, we have a lot of healthy and athletes as well too, since we're located right next to the university as well.
Right. And then someone asked about everyone that comes through the fit core is Indiana, and the population, the INPC is the Adamart is also all Indiana. We're a little, so population wise, we actually, since in our CTSI grant, we always talk about this. We actually are very representative of the US in terms of overall population, Hispanic, Black, etc. But in the cohort, we're really, unfortunately, mostly white at this point. So we're really doing trying to do some more community engagement to get a more diverse sample. So that we purposely in the Z-scores, correct me if I'm wrong, Stuart, made it all white because that was the population we had. So we're working on that. I think I got all the chats.
I think you did too. Any other questions?
So please spread the word. I mean, sometimes you feel like we've done all this work, we build this huge cohort. We really want investigators to use it. As Stuart and I were talking recently, there's so many papers that we want to get written here but there's also so much data that that the NIMS has put the money into building, that we really want to make sure we let everyone know. And that's a struggle. I don't know if anyone else has found the same thing, trying to get more and more people and to engage them in utilizing what we build. So this is the best way to get this across.
Yeah, I think this is a great network to help do that. And it strikes me that your mission is fairly broad, which, it widens the pool, obviously, but it can make it more challenging to figure out how to target people who are potential users.
Right, right. And, we try to booth at the ASBMR, for example, and other things, but word of mouth, I think, is better than anything. So, yeah.
Right. If there are no other questions, I don't see any in the chat or any hands, we can end here. And thank you again, Dr. Mo. And I think there will be maybe be a poll afterwards. I'm not sure. Maybe that's just for speakers, but
I'll launch the poll at the end.
Okay, great. Thank you, Abby.
Mhm.
Yes. Thank you
Thanks,
for
everyone.